one of the important thing, intestinal obstruction. So this will be taken by Dr. Sreedevi. She is a palliative care physician. He is working here in Pallium, India. She did her certificate course in pain and palliative medicine from TIPS and fellowship in palliative medicine from Calicut and MSc palliative care from Cardiff University. She has more than 8 years of experience in palliative care. She is a well-versed person in this field. Welcome, ma'am. Over to you.
Thank you, Sister Shiva and Raju. Raju, someone in the chat is mentioning that they can't hear anything. Want to ask them?
What about the rest?
So, I can hear very clearly.
Then that might be the network connectivity of that area, ma'am.
So whoever is not hearing, just enable your computer audio. It will be, you just click on the voice button, you can enable your audio. That may be a reason. Okay. So thank you so much for the introduction. And it is always glad to talk to nurses because we always learn from each other. We talk to them and we learn from them, and we'll share our experience with the nurses. So it's always a pleasure for me to talk to a group of nurses always. So I understand there are nurses from different parts, like not only from India and from outside, right?
Yes,
Okay, so
ma'am.
there may be a change in medications, everything that I may mention. So just ask me whenever you feel lack of clarity. And today's session will be focusing mostly on malignant bowel obstruction. I have gone little bit more detail into the pathophysiology and stuff, which is usually taken in that much detail for doctors. But I feel that nurses should also understand how it happens and why it happens, because you play a major role in talking to patient and explaining them what is happening. They may not ask us, doctor, what is happening, but they may ask you, why am I vomiting, or why is the symptom happening to me? So you should have an idea about what is obstruction, then only you will be able to answer their queries. So I have touched a little bit in detail about malignant bowel obstruction. If there is any confusion, I'll try to simplify as much as possible, but if there is any confusion, just stop me or raise your hand. Someone can tell me to stop. Okay. So I'll share my presentation. Okay. So today we will be dealing with mostly with signs and symptoms with a radiographic evidence obstructing the transit of GI content. So today we'll be talking about any kind of obstruction that is blocking the transmission of GI contents, mostly related with cancer and anti-cancer treatment, because obstruction is a broad area. It can happen even in neurologic illness, so it is out of scope for discussion. Today, we'll focus mostly on patients with a cancer and anti-cancer treatment. That is why we call it malignant bowel obstruction, not just bowel obstruction. So it is a little bit difficult area because the signs and symptoms vary from person to person. So you really need to think how to manage this particular patient. You cannot have a simple formula and give it to everyone and treat, but you should understand each patient's signs and symptoms very differently, and according to that we need to plan our management. So you can see that it is written that expected median survival is 1 to 3 months. What does that mean? When a patient is having a bowel obstruction, they are likely to die within 1 to 3 months. That means it is a very bad prognostic factor. Once a patient is having a bowel obstruction, highly likely that they may die in another 1 to 3 months. So I'm telling you this because we need to start communicating regarding the prognosis at this point, right? Because you still have few weeks to talk to them and prepare them for what is going to happen. So the median survival is very less when a person is diagnosed with malignant bowel obstruction. and it can occur anywhere in the GIT from esophagus to rectum. So starting from esophagus till the end. So from the beginning to the end of GIT, anywhere you can have a obstruction. Usually it is a most common site. You have to remember all these points. Most common site is small bowel. And we may think that it is most commonly seen in intestinal cancer, right? Because it is a bowel obstruction. So it might be common in colon cancer, but it is most commonly seen in gynecological cancers, usually with ovarian cancers. Okay. So we'll come to different types of obstruction. There are so many types. We can classify it according to site, according to where it origin, from where it is compressing. So there are so many classification, and this is also really important, because then only we'll be able to understand from where it is happening and why it is happening. So we can tell that there can be mechanical and functional obstruction. I'll come into detail when I'll be explaining each one by one. There will be partial or complete obstruction. That is very evident, right? Partial block and complete block. Single site, multiple site. I don't need to explain it, right? The obstruction can be at a single site, anywhere from esophagus to rectum, or it can be at multiple sites. And all these points are important, because all the signs and symptoms and the prognosis, everything matters according to this classification. So what are the it can be intraluminal or intramural. So it can be due to any tumor or swelling inside the lumen or from the mural lining of the intestine. Or even I mentioned, do you remember I just mentioned that obstruction is really common in gynecological cancers, especially in ovarian cancers. So how it happens in ovarian cancers? Obstruction from outside. So the big you know that ovarian tumors are usually huge tumors, large size. So there can be obstruction to the GI tract from outside. So these kind of obstruction are called extrinsic obstruction, which is the commonest type. So how a functional obstruction can occur? Many people will be undergoing surgery. Very commonly, obstruction happens after surgery. So what happens after surgery? There are a lot of adhesions. So adhesions can cause obstruction. So obstruction can come as a side effect of already done surgeries. And some of the reactions to chemotherapy. Many chemotherapeutic agents can cause desmoplastic reactions, which can cause a block in the GI tract. Torsions, not very common, but it is another reason for obstruction. You know that when one tumor is there and it just goes upside down like a torsion, it just goes to another direction, which can cause obstruction. And there can be internal hernias. So very rarely, we can see intestinal pseudo obstruction. That, for example, I will say there is a pancreatic tumor, so the tumor is obstructing the neurons. So what happens? The nerve supplying the GI tract is not working. So the gut is not at all moving. So what happens? It looks like a tumor obstructing the GI tract. But it is not actually the real obstruction. It is a pseudo obstruction, because the nerve supplying to the GI tract is completely destroyed due to many reasons. And some drugs can you know that morphine can cause delay in peristaltic activity. So in terms of morphine induced delay in peristalsis, it looks like bowel obstruction many a time. So many drugs can cause ileus. Even in diabetes, diabetic neuropathy is not just affecting your peripheral nerves, but it affects most of the neurons. So it can also act like a obstruction. So people with diabetic neuropathy can come to you with presentation of features of obstruction. So these are rare occurrence, but these are another chances for another reasons for having obstruction. I'll just switch off my video so that okay. So I'll just briefly mention about how the obstruction happens. So imagine a tube. It is literally like a tube, right? The GIT is literally like a tube extending from your mouth to the rectum. So it's a huge tube. Anywhere in the tube you can have block. So what happens whenever there is a tumor inside the tube? So just remove from your head about the GI tract, esophagus, stomach, everything. Imagine just a tube. So anywhere in the tube, if there is an occlusion of the lumen, anywhere in the block in the tube, there can be a block. So when there is a block, what happens? Our body tries to bypass the block. So it moves vigorously so that whatever we eat should bypass the block. So that happens initially. So there will be slight colicky pain, lot of noise from the abdomen. People will tell you there is a lot of noise from my abdomen because your intestine or your GI tract is trying to bypass whatever obstruction is already happening. So it tries to push the food content or whatever secretions are there to move beyond the obstruction. But what happens, there will be slight colicky pain or colicky peristalsis, and there will be slight distension also. So this is a reversible time. This is a sub-obstructive phase. There will be slight obstruction and your GI tract tries on its own to overcome this obstruction. Sometimes it will succeed. So it is a totally reversible phase at the beginning. So what happens? So although there, if there is, so GI tract is trying, right? Your gut is trying to overcome the obstruction, but nothing is happening. But it still continues to try. It will not give up. It continues to contract. What happens? The peristalsis become haphazard. We know that our peristaltic movement are rhythmic movements, right? Contraction, distension, contraction. That is how the food contents are propelled. Whenever there is a block in the tube, everything goes haywire. The peristalsis become totally uncoordinated. So the patient will tell you more and more colicky pain, and the bowel become more and more distended because it is trying, but it is not overcoming the obstruction. There is more distension. So whenever there is more distension in the abdomen, there will be more secretion. You don't need to look at the PPT. It is just a cycle, just few words. You may not be able to understand from the slide. So there is a block. It is trying to overcome the block, unable to overcome the block. So everything goes haywire, uncoordinated peristaltic activity. And any time there is more distension, what happens? There is more fluid secretion. More and more fluid secretion means there is more and more distension. So it is like a cycle. More distension, more secretion. More secretion means again it is getting blocked. So there is more distension. So in reaction to distension, there is more secretion. So everything becomes a cycle like process. And whenever there is more obstruction, you know that all contents are blocked, right? Blocked above the obstruction site. So there will be overgrowth of bacteria. Whenever there is, so it's like a sewage. When your sewage is blocked, what happens? There will be more, after a few days, you will get smell. The waste get accumulated, the flies start coming, the mosquitoes start breeding. So there is more and more bacteria. The same thing with the gut. If it is not moving properly, if it is stagnant for a few hours, more or few days, more bacterial overgrowth. So whenever there is bacteria, there is inflammation. To fight the bacteria, what happens? Inflammation happens. So there will be pain also, more gases. Whenever there is bacteria, inflammation and gases will be there. So the patient may tell you, I have a feeling of gas not coming out from above. I'm not able to burp it out. So many complaints the patient will tell you. And whenever there is an inflammation, you know that. Okay. So whenever there is an inflammation, we know that there will be prostaglandins, everything come into action. And there is bowel wall edema. So what all things happened? You know that there is a block in the tube. The tube tried to overcome the block, completely failed, and the block is growing bigger and bigger. So upside parts, the fluid gets accumulated. When the fluid gets accumulated for a longer period of time, your tube becomes bigger and bigger. That is called distension, right? The tube becomes bigger and bigger and bigger, like a balloon, and there is more distension. And when the contents are not moving, it becomes old and bacteria starts growing in that. When bacteria starts growing, it will emit lot of gases and produce inflammation. Whenever there is inflammation, we know that if you cut your hands and you have inflammation, there is edema. Same way in the abdomen, if there is an inflammation, the bowel wall will have edema. What happens when there is edema? It is aggravating the block again. Already the tube is blocked, and again the tube lining is also edematous. So the tube is completely blocked. Everything became a mess, completely obstructed. And whenever there is an obstruction, there is and you know that now the bowel is all distended like a balloon, and the wall is also edematous. So there is less blood flow to the area above the obstruction. Everything changes, the blood flow changes because there is a block, right? So blood cannot flow freely. So this can cause hypoxia and later on multi organ failure. So that is how a simple obstruction can end up in patient's death. So why? What are the consequences of having obstruction? I know that it is a little bit unclear or foggy. Is there anyone who wants more clarification? I can tell you again. Can someone raise their hands if it is unclear till this part? Is it clear till this part? Why? How? What happens when you have a block? How the GI try to? Yes, there is someone who raised their hand. Regina.
Good morning. Yes, please. The pathophysiology again. I'm quite confused about it. If you could go over one more time.
Yeah, sure. Definitely. So
Okay, thank you.
no problem. You just ask me how many times you want. I can tell. There is not at all a problem. Okay. So whenever this slide is just a reminder for me. That's it. So you have a tube. You have a small obstruction. The tube got clogged with waste or some obstruction. Something got into your tube. So what happens? Our gut has some sense, right? So it tries to overcome. It tries to push the contents across the block. So it moves. What happens? The GIT moves suddenly, causing lot of peristalsis, trying to overcome the block. Sometimes it succeed in overcoming the block. Sometimes it will not succeed. If it succeed, then it is fine. It resolves on its own. But suppose it cannot succeed, everything goes haywire. The block is there, your tube is trying hardly to push the contents across the block, but what happens? It is not succeeding. So above the block, everything gets blocked. It is like a hose that we use in our home. We use the pipes, right? The hose, the flexible tubes. So when there is the water is flowing from the tap continuously, and there is a block in the hose, what happens? The water will get accumulated above the block. So the hose, if it is flexible, it will start expanding. That means more distension in the GIT. You know that our GI tract muscles are very flexible. It's like a balloon. So it keeps distending. The more and more it keeps distending, the more and more fluid will accumulate. So if the fluid is not moving for many days, it becomes dirty. The bacteria will come. Once the bacteria will come, the bacteria will produce their toxins and gases. So more and more distension. Everyone is blocked above the level of obstruction. Nothing is passing below. Everything is blocked above the obstruction. So this will cause a block in the blood supply also. Blood will not flow freely from above the obstruction to below the obstruction because there is a blockage of blood flow. Everything is distended and compressed. Blood vessels are all compressed. So there is no blood flow also, which will cause hypoxia, hypotension, and other complications to every other organ. This is just for your understanding. It is really good to understand why this happens. Otherwise, when the patient is telling you, I have all these symptoms, I have a bloated feeling in my tummy, I feel like vomiting, I can hear noises, I feel that gas is not passing properly. So you will be able to understand, okay, that means there is a block somewhere and this person cannot pass the contents below it. This is what is happening. This just for your understanding. Is that a little bit clear than before?
Yes, ma'am. Very clear now.
And
Thank you.
okay. So there are a lot of consequences when this happens, not just this distension, pain, and stuff. There are so many other complications. Even I didn't know that a bowel obstruction can cause these many complications. This I came to know only after I started seeing patients, and then I thought, why this is happening? Why a patient with bowel obstruction is coming with a hypotension? Why do they have a sepsis? It is after all just an obstruction in the GIT. Why does this happen? So that is how I came to know that there are a lot of complications happening when you have a simple malignant bowel obstruction. What happens? There will be, I said that there is a problem in the blood flow because everything is obstructed. So blood flow to the kidneys are also reduced, which will cause a renal failure. So whenever there is a renal failure, there will be hypovolemia and all those complications. And suppose you have a distended abdomen, it will push your diaphragm up, right? Your abdomen is distended, and you have a diaphragm just above your abdomen, and it will push the diaphragm or elevate the diaphragm. What happens? There is decreased pulmonary ventilation, and your GIT is completely edematous, and all the bacterial toxins will leach outside the GIT and can cause sepsis. So these are all simply the complications. So the patient may end up in having a renal failure, hypotension, pulmonary ventilation, decreased pulmonary ventilation. So they'll tell you, I have breathlessness. So you might have seen people with huge ascites and um, telling you that I am breathless. Huge abdomen and telling you I am breathless, because the abdomen is literally pushing your diaphragm up, which will cause decreased pulmonary ventilation. They can't breathe properly. We know that the air get in the lungs, and the diaphragm will have to come down to give more space for the air. So everything is compressing your diaphragm and you cannot breathe properly. So that is how it happens. So now we will come to the symptoms. What are the symptoms? This is really more important than the pathophysiology. Pathophysiology is for our understanding, our clarity of things, what is happening in the patient that we treat. Symptoms are really important things that you should focus on. So there can be obstruction anywhere in the GIT, right? From esophagus to the rectum, anywhere. So whenever the obstruction is at a higher level, which I have written, higher the obstruction, more will be the symptoms and less will be the signs. And whenever the obstruction is at a lower level, the symptoms will be less and there will be more signs. I'll explain a very easy way to get this in your mind. So what happens when, so imagine the wash basin or a sink in your home. So your wash basin got blocked, okay, right at the outlet. Wherever you have that wash basin outlet, the wash basin got blocked. So you go and wash your hands. What happens? Someone tell me. Your wash basin has a long tube starting from just below the wash basin till the outlet outside your home. Okay, so you have a block, you have a wash basin, and the block is just below the wash basin, just at the site of outlet. What happens when you wash your hands or when you spit on it? Simple question. You don't need nursing or medical degree to answer this. What happens? I need an answer, otherwise I won't.
Water will block
When? Immediately or later?
later.
The block is just below the wash basin, just at the outlet.
Yeah, immediately.
Immediately. And what kind of water will be it? Like, will it be really old kind of water or a fresh water that you just washed? Usually fresh, right? Because you just wash your hands.
The all the obstructions.
Yeah.
Yeah,
Tell me.
yeah. The all the obstruction will be there. But
Yes.
if there is any leakage and all, the water will go, but there will be obstruction.
Yes.
And immediate they happen. This is process.
Yes, exactly. And Sister Regina, you want to tell me something? What happens then? Thank you,
Yeah, so I think that
Shashi, right? Shashi Shekhar. Thank you so much for your initiative.
Yeah, ma'am. Yeah,
um,
welcome.
I have typed in the chat box, but I was saying that if the block is just at the outlet,
Yeah.
just directly below the wash basin, then it means that when you wash your hands
Mm.
or you pour something into it, it will not be able to flow down through the tube and then get outside the drainage outside the home. So the water or whatever you are pouring in will be accumulated in the wash basin. It will not be able to flow down easily
Yeah.
through the tube to get outside. Yes.
Exactly, exactly. Thank you so much. So that is the easiest way to remember the signs and symptoms. What happens when you have a gastric outlet obstruction? You have a block just below the wash basin, early and severe nausea and vomiting. The water comes out. Whatever the patient eats, immediately after that, the patient vomits. Right? Does it make any sense? You can relate it, right? Early nausea and vomiting, and usually the food contents will not be like foul smelling. They will say, morning I have a tea and the tea just comes out in the same color. I had some rice gruel or oats or porridge, whatever. Immediately after that, I vomit the same contents. Large volume, early and severe nausea and vomiting. And what happens in small bowel obstruction? That means your wash basin tube has gone along 1 or 2 meters, and there is an obstruction. So you can wash your hands from the morning, afternoon. You don't think that there is an obstruction. You keep washing your hands. It happens in every household, right? At by night, everything comes up. Oh, there was a block somewhere down. And what kind of block will that be? It will be really smelly water, right? Because you might have been washing your hands and utensils, everything from morning. Everything is going down without any problem till night or till afternoon or till evening, and after that, then the whole tube gets filled up and then it comes out. So that exactly happens in a small bowel obstruction. I'll come to the more cramping side. So people will tell you, I had my breakfast, I had my lunch also. I think there is some problem with the dinner because every night after the dinner I vomit. So I think I should change the dish for dinner. I think I'm not doing good with the porridge that I'm taking at night. It is not about the porridge that they are taking at night. Everything goes in without any problem till the tube gets filled up, and after everything, it comes out. Okay. So easy way to remember. So symptoms appear later. The patient will keep drinking or eating in the daytime, or we will keep washing our hands in the wash basin, or we'll keep washing, and there will be considerable distension. And you know that the water has been accumulated for many hours, so there can be bacterial overgrowth when your obstruction is distal obstruction. And whenever there is bacterial overgrowth, it will produce more gases and there can be diarrhea also. So this is how I used to remember the bowel obstruction. I hope it may be helpful for at least some of you, so that you will not forget. Otherwise, we used to by heart, higher the obstruction, lesser will be the symptoms, more will be the signs. It is very difficult to by heart that way. So this is the easiest way. Upper the obstruction, the signs will be less. So there can be two types of pain in terms of obstruction. And this is really important for nurses or anyone treating the patient, because when the patient is telling you, you might have learned in nausea vomiting session, you should not stop with, do you have vomiting? Yes. It is not over there. Ask them, when do you vomit? Is it immediately after food, or you can hold food for a few hours? What kind of vomitus? It is foul smelling, or is it unchanged food is coming out? What is the volume? Is it a large volume vomitus, or is it just small volume vomitus? So everything you have to ask in detail. Pain can be of two types. We'll come to the symptoms. A patient will tell you, I have a continuous background pain and I have cramps in between, and which this cramps usually happens after meals. Why after happening after meals? We told initially. That is why we learned pathogenesis. The gut is trying to overcome the obstruction. It is trying to push all the meals so that it should go down, but it is not happening, which will cause cramps immediately after taking food. Lot of peristalsis happens. And in large bowel obstruction, the nature of vomitus is really important. Some people do vomit fecal matter. It is not uncommon. So don't hesitate to ask them what color it is. Do you think it has a smell of feces? And some people, they won't tell you immediately, but you have to ask, and then they will tell you, yeah, I think I am vomiting fecal matter. And In gastric outlet obstruction, all the biliary secretions will come out. It is not that foul smelling vomitus, but in case of a large bowel obstruction, there can be even fecal matter vomitus. So the first symptom was pain, the second symptom was nausea and vomiting, and the third symptom is constipation. Very important question in bowel obstruction, are you passing gas? If the patient is telling, I'm not passing gas, you should think about a complete obstruction. If there is some small space, gas will escape. So it has to come down. That means it is partial. If the patient is able to pass the flatus, then the obstruction can be partial. Flatus and stool are completely absent in a complete obstruction. And always listen to the bowel sounds. Make it a habit just to listen to the bowel sounds. Sometimes it will be loud noise coming out of the tummy because of the gut trying to overcome the obstruction, lot of noise. Sometimes the gut will be completely silent. It will not move at all. For example, morphine induced functional obstruction. The gut will not move much. So you can see, okay, there is a decreased bowel sound. When you have a lot of gut activity happening trying to overcome the obstruction, that means a lot of noise will be there. So this is to tell you how it is different in um, small bowel obstruction and a large bowel obstruction. So proximal means closer, more towards the wash basin. Distal means far away from the wash basin. So what happens, it is easy to remember that way. When you have a block near the wash basin, you have severe cramps, early symptoms, early vomiting that we mentioned, and their pain will be mostly around the umbilicus. But what happens when the block is away from the wash basin? The symptoms will appear really late and deep visceral pain because it is far down. So the pain will be deep visceral pain, and cramps will be, there will be long intervals between the cramp because the food will take time to reach there and then the cramp happens. When it is outlet, the food will reach immediately there and the cramp happens. And what is the difference between the vomiters in terms of proximal obstruction? As we mentioned, the moment you wash your hands, large volume of water will get accumulated and no or little foul smell. Usually it will be clear water or undigested food. And in terms of block away from the wash basin, little by little coming up, right? You by the night, little by little water is coming up and there will be foul smell and there will be bacterial overgrowth and other symptoms like diarrhea. And in terms of distension of the abdomen, usually there will be less distension in proximal obstruction because you are just near the wash basin. There is no time, there is no place for distension. But when your block is away from the wash basin, what happens, there can be chances of severe abdominal distension. There can be constipation very commonly in proximal obstruction, but in distal obstruction there will be definitely long standing constipation. So is it clear till here? Because we are moving on to the assessment and management part. Are the symptoms really clear in terms of bowel obstruction? What happens in distal? What happens in proximal? How will be the pain? How will be the nausea, vomiting, and what is the difference between two sites? Is it clear? You can type it in the chat if you want.
എങ്ങനെ വരുമെന്ന് നോക്കാം.
Okay, can we move forward?
Yes, ma'am.
Okay. So evaluation. So very rarely it will come to you as an emergency. You will get a hint very early that this patient is going to have a bowel obstruction. So the moment the patient is coming to you, you should evaluate. Is this patient is going to live for a longer period of time? What is the stage of illness? Is he in the very advanced stage of cancer, or is it just the beginning of single site or very good prognosis kind of cancer? So our aim is to address the pain, nausea, vomiting, and fluid status. The patient will not tell you that I have a bowel obstruction. What will they tell you? I have pain, I have nausea, vomiting, and I have constipation. Just focus on those symptoms. The moment you start focusing on symptoms, everything will be falling into place. We don't need a big investigation spectrum for this bowel obstruction. Check you as a nurse, you have to check whether the patient is properly hydrated. Is there any signs of dehydration? And I would generally check electrolytes, whether there is hypokalemia, because it can reduce the bowel movement. So just to rule out what is happening, nothing big, no big investigations are needed. So this is one investigation. If I have an radiology unit nearby, I would just go for an abdominal radiograph. The abdominal radiograph have to be erect abdomen, not on a lying position. The patient has to stand and take the x-ray. And you can just Google in the internet how a bowel obstruction looks like in an x-ray. This is the classic figure. You can see multiple levels. You can see like lines, and above that you can see radiolucent regions, right? uh, yeah, this is a clear picture. You can see lines here. It's very distinct lines, right? So this is called multiple air fluid levels. When you see this picture, it is very classic picture of a malignant bowel obstruction. When you see this in x-ray, you can be sure that the patient is having a bowel obstruction. It is usually seen in distal obstruction, because the contents get accumulated for a longer period of time, then only we can see it in the x-ray. So usually we take a plain X-ray abdomen, and when the block is near to the wash basin, you cannot see an X-ray, much of an X-ray finding. But if it is distal obstruction, you can see multiple air fluid levels. And this is very important, because then you can rule out whether it is a pseudo obstruction. Usually this will do, but if you have a good facility and big hospital setting, you can go for CT scan. So what is the advantage of CT scan? It is the gold standard for ruling out bowel obstruction. So you will be able to understand where exactly is the obstruction, whether it is inside the lumen, whether it is outside the lumen, whether it is single site, multiple site. So everything will be, and what is the status of area around the obstruction, everything will be clear in a CT scan. So if you are in a setting where you have a big cancer center, you must be seeing your doctors sending the patients for a CT scan. But in a pure palliative care setting, an X-ray erect abdomen is much more than what we need. So we'll come briefly to the management. So this is completely a nursing part. Frequent mouth care, because the patient is continuously vomiting and unable to eat things. So the mouth care really sucks. They keep vomiting. So you really have to look into the oral cavity. There can be a lot of ulcers because of continuous retching and vomiting, and poor oral hygiene. So check whether the patient is dehydrated, whether there is dry mouth, cracked lips and tongue, and tell them to suck small quantities of ice or sips of fluid. They can't drink even spoonfuls of fluid because they may vomit. So tell them to just moisten their tongue and the lips by cotton or fillers or something. And if the patient is really dehydrated and the general condition is really good, then you can start a IV hydration. But if you think that the patient is not dehydrated, but he may have a lot of fluid loss because of vomiting and his general condition is not that good, then you can have a subcutaneous fluids for maintaining the hydration. And choose the route of administration. So the person coming to you with continuous vomiting, I can't tell them to take tablets, right? They will vomit. So I have to choose whether I need to give a subcutaneous, whether they are in a home-based setting. Should I need to think about rectal? Should I need to think about any nurse nearby so that they can come and take the injections? So I can't just prescribe medications and send the patient back home whenever they have a bowel obstruction. I have to choose the route of administration really wisely. So we mentioned about, I'm just revising again. We mentioned about symptoms. What are the three main symptoms? The patient will be having pain, nausea, vomiting, and constipation. And the fourth symptom will be abdominal distension, which happens only in distal obstruction. So coming to pain, you all have learned about pain medications, right? Usually they will need opioids. So what if I give them tablet morphine? The moment they take tablet morphine, they will vomit. The tablet morphine is absorbed in we don't know whether the obstruction is beyond the level of absorption, whether it is going to get absorbed properly. So I cannot be sure whether if I give tablet morphine. So I would prefer either subcutaneous or intravenous route or even rectal route. But if you are working in a setting where you have patches of fentanyl, you can even choose fentanyl only after you stabilize the pain with the systemic route. So opioids are the drug of choice usually, but think wisely how you want to give. Think because I'm telling you this because many a times, I myself have done that. We just prescribe medication and then suddenly the nurse comes and asks me, he's vomiting, how can I give the tablet? So that is your duty to remind if that happens, doctor, the patient is vomiting, I can't give the tablets. Would you want to change it to the subcutaneous or intravenous? So that is something you can also help in thinking. The next option would be steroids. Steroids are the drugs for malignant bowel obstruction. Don't forget the role of steroids in bowel obstruction. And I told they have colicky pain, so you should think about antispasmodics. So we'll come one by one. So this dexamethasone is the drug of choice or steroid of choice for many of the conditions in palliative care. Um, so have they mentioned anyone mentioned about the dexamethasone dosage, why dexamethasone and everything before during nausea, vomiting?
Yes, ma'am.
Yeah, okay. So usually we give dexamethasone anywhere from 8 to 16 milligram. We give it subcutaneously and we try for 3 days and see whether the patient is responding. So what is the role for, so a few things, I think Sister Stella might have taken nausea, vomiting.
Yes,
No.
ma'am.
Okay, so she might have mentioned about the how to give injection, whether rapid or slow, everything she might have mentioned, right?
No.
Okay. So dexamethasone, we prefer dexamethasone because it has longer duration of action and it has less of mineralocorticoid activity. That means you are not going to have much of the side effects like other steroids. But dexamethasone has a problem. If you are giving it for a longer period, you have to check the blood sugar. It can cause glucocorticoid action. That means your blood sugar level will rise. So if your patient is on dexamethasone high dose for more than 3 days or 5 days, it is ideal to check the blood sugar at least once in 3 days or 5 days. So we usually start with OD dose of dexamethasone. You might be seeing in your setting BD and TID doses of dexamethasone, but higher doses of dexamethasone, if you give 8 milligram dexamethasone at night, the patient is not going to sleep. It can cause insomnia because the steroids, it sets your biological clock. Our body has its own steroids that will remind you, okay, morning, get up, start your activity. And the steroid will come down in your body by night. So then we know that it is time to sleep. So whenever your body itself has a mechanism which will reduce steroid by night and you are injecting a big dose of steroid at night, the patient will be awake. So body's mechanism itself is high steroid during the morning and low during the evening time. So it is better to give once daily dose. And whenever you give a subcutaneous injection, you cannot give more than 2 ml as a bolus injection. And dexamethasone injection has to be given really very, very, very slow. You literally have to have lot of patience to sit there, and it is a really slow injection. Otherwise, if you give rapid dexamethasone IV or even subcut, usually with IV, you have perianal sensations. You feel tickling. I personally have experienced that. I didn't know then what was happening there. So they had to give for some allergic reaction or something. So they gave me a high dose of steroid and the nurse pushed the steroid. And as soon as I felt something is happening down, I couldn't even tell what is happening. It's very embarrassing feeling and you really feel in distress. So it has to be really, really slow. And so what we do in our setting is, if you don't have time to sit there and adjust this thing. You just mix it with 100 ml saline and put it as a subcutaneous infusion. So it will go really slow. You don't have to worry about a rapid bolus injection. And if you cannot, for example, 8 mg means 2 ml, 16 mg means 4 ml. You can't push 4 ml together. So you can divide it into two. You can give 8 mg in the morning and 8 mg in the afternoon and go with a very slow, very slow injection. So what happens when you give dexamethasone? It will reduce the, I've written it as a heading, it reduces the bowel wall edema. So whenever there is a tumor, there is something called peri-tumor edema. Whenever there is a tumor, there will be edema around the tumor. When you give steroid, the tumor around, the edema around the tumor will reduce. So you will get a little bit of space there, right? The obstruction is, the tumor is completely obstructing your GIT. You give dexamethasone, after 1 or 2 days, you can see the edema around the tumor. It will not reduce the tumor size at all. It will reduce the peri-tumor edema. So you can get a little bit of space so that you can push your contents through that space. It is exactly like removing a traffic block. If you try to push the vehicle through the side road, everyone get blocked. If you make a space on one side and then one by one you start pushing the vehicle will go from the traffic block. It is exactly like that. So you give dexamethasone, you reduce the edema a little bit, then you give a prokinetic. The prokinetic would be metoclopramide. So now the edema is reduced, you got 1 or 2 millimeter space there. Now you give something to push the contents. Was there any question, Sister Shiva, or?
No, ma'am.
Okay. So, so you give steroid, reduce the edema, you made a little bit of space and you give a prokinetic. When you give a prokinetic, there is a chance that the food will pass through the unblocked area. But ask the patient. So this is again a nursing part. The moment you start a metoclopramide injection, wait whether the patient is telling you that I have a colicky pain. Sister, with the last injection, my pain increased. That means you don't have space to bypass. It can be a complete obstruction. Immediately, you have to stop the prokinetic. Otherwise, you can cause a perforation. So ask after metoclopramide infusion or injection, ask whether you have an increased pain. That is your role in that. For when complete obstruction, you have to change all these medications. So now you tried metoclopramide and you came to know that the obstruction is, the pain is increasing. It is a complete obstruction. I can't do anything to bypass the obstruction. Now you give something to paralyze the gut. It is called gut paralysis, completely calming down the gut so that it is not moving, it is not secreting anything. So these are the drugs used to reduce the secretions. Hyoscine butyl bromide, in our place we call it Buscopan. There is another preparation called hyoscine hydrobromide, but hyoscine butyl bromide is more efficient than hyoscine hydrobromide, because in other countries you may have hyoscine hydrobromide. Ranitidine infusions at a rate of 200 milligram per day. And there is a drug called octreotide, which is a somatostatin analog or VIP inhibitor. And octreotide is a combination cocktail of everything. It will reduce the vomiting, it will reduce the edema, it will reduce the pain also a little bit. So that is also again given as, I'm not focusing on the dose because you may not need to prescribe all these drugs, but you should understand when and why these drugs are prescribed and what is to be noticed. And now we have managed pain with opioids. We tried to bypass the obstruction with dexamethasone and prokinetic, but your block is complete and the patient is telling you that I have a colicky pain. Then you try to reduce the secretions. Now you need to focus on nausea and vomiting. Either you can give haloperidol, a small dose of haloperidol. Usually we don't use promethazine, but textbooks say promethazine. That is why I have mentioned it here. So constipation, you cannot be really aggressive with the constipation management, because when it is a complete obstruction and you are giving something like a Buscopan and the gut is not moving and you are expecting the patient to open his bowel, not possible. You are paralyzing the gut and you think that the patient is going to pass motion or fecal matter, not possible. So you have to have some logic when you do all this. So gentle rectal measures. Sometimes when you give bisacodyl, a patient will tell you, I have colicky pain. So ask for more distress when you give any drug. So there are a lot of surgical options. You might, if someone is working in a cancer center, you might have seen all the surgical options. But our intention should be to improve quality. Usually the surgery is done only to improve quality of life and symptoms. So suppose your patient is asking you, sister, I had a surgery with so you know that the patient is having bowel obstruction. Sister, I had a surgery, so do you think my cancer is removed? No. Usually surgeries are done in bowel obstruction usually to palliate the symptoms. Usually the surgeries are palliative surgeries, just to reduce symptoms. NG tube insertion, what happens? It is very, very common in hospitals. The moment you have a bowel obstruction patient, you put an NG tube and keep it there. So that you think that you can drain out everything, but the caregivers will think that, there is a tube, I can start feeding the patient, right? So the NG tube insertion is indicated just to evacuate all the intestinal contents, then you take it out. It is very, very temporary measure. If you think that it is a large volume vomitus, you can put in a tube, and so that the vomiting, whatever secretions are pooling in your stomach can come out. So we had many patients who really wanted, who knew that they are having obstruction and they are going to die soon, but they wanted to eat whatever they want to eat through mouth. So what they used to do is like they eat through the mouth, and the moment they start feeling distension, they themselves will drain, open the NG tube and drain all the secretions out. They were managing like that for many days at home, so they could eat whatever juices or whatever they biryani, and someone wanted to have some biryani, and he knew that it is going to cause a distension and lot of issues. So the moment he starts feeling a discomfort, he used to drain the fluid out. So he was quite happy because I could eat, instead of vomiting, you can just take the fluid out. So there are other surgical measures like gastrostomy, not it is also only for symptom management, not as a curative measure. Stenting, very, very commonly done, but it is with a very, very bad prognosis. Usually what happens, after a few days, the stent will fail, and it will be very difficult to manage if the patient had a stent. And usually they give radiotherapy if the obstruction is single site. If you have a single site obstruction, the prognosis is much better. Total parenteral nutrition is indicated, depends. Suppose my patient has a single obstruction, he's going to undergo surgery, very good general condition. So maybe for 1 or 2 days, they may give total parenteral nutrition, but it is not at all indicated in an advanced malignant bowel obstruction. You are overloading the patient with the fluid, and the patient is going to have a lot of difficulties out of that. So what is the summary? They require, so the moment you see a patient with bowel obstruction, you need to understand at what stage of disease trajectory they are. Where are they standing? Are they dying? Are they a person with good general condition with a single site obstruction? So then only you can answer to their questions. How aggressively they will ask you, sister, do I need to do a surgery? So you have to understand what stage of illness they are. What should you tell them? And pain, nausea, vomiting can be addressed by medications. You can give parenterally, sublingually, or transdermally, or even rectally. And the patients and families can be made comfortable through the medications and good psychosocial support. So that is...
Thank you, Dr. Sreedevi, for the detailed presentation. So is there any questions? Please ask. Either you can chat or...
There is a question. May I know how to indicate patient for TPN? So I'll tell you an example. Suppose I have a good general condition patient, single site obstruction. Okay, so he's waiting for surgery, a curative surgery, or a good prognosis surgery. He's waiting for surgery, but he's unable to eat, and he has to be really fit for the surgery. It is not even palliative surgery. So then maybe till he undergoes that surgery, he can get good total parenteral nutrition, maybe for a few days, till he undergoes a curative surgery. I think that is the indication for TPN. So, patient diagnosed with HCC, and what is the question? Michelle, what is the question? You can type completely. Patient diagnosed with HCC. What do you want to know on that?
You can even unmute yourself and speak. Michelle Fan.
So there is another question, whether TPN is really helpful in intestinal obstruction. Not at all. So what is the indication? You have to, when I say not at all, as I said, you should understand which stage the patient is in. Which stage the patient is in. Is it patient that completely treatable? Generally, most often bowel obstruction is a very bad prognosis thing. But very rarely you can see a patient with single site obstruction and as I said, waiting for a curative surgery. Then maybe, but generally it won't help. It is damn expensive, and the moment you start TPN, patient will think that okay, I'm getting something so that I become immortal, some good thing, because it's really expensive and they put a lot of hopes in that. So I have never ever given total parental nutrition in any of my patients.
Hello.
Michelle.
Hello. Yeah, can you hear
Yeah.
me?
Yes,
Yes. You can.
Yeah. It's regarding my patient. He was diagnosed with this HCC, and then these 2 days, his abdomen is very distended, so ascites actually noted lah. Then today I went to hear. He claims that he did pass motion, but small, soft, but minimal only, brownish too. And then when I hear his vowel sound today, I can't really hear anything. And then when I do my PR, I noted there is ballooning and there is a stain of stools, which is like a bit hard and brownish stools. Does this mean that there is a possibility of obstruction, or because it's ascites that I can't hear the vowel sound?
exactly. So that is one thing. Because of ascites, you may not be able to listen to the vowel sounds. Sometimes the vowel will be pushed to one side. Usually, wherever we look for vowel sounds, you will get it in. You may get it in some other location. You can, because the vowel will be pushed to some other side. So you can look everywhere wherever you have vowel sounds. So ascites, it is very difficult most often to get the vowel sounds. And as you said, there is a chance of obstruction even with hepatocellular carcinoma, because whether they have a huge liver, hepatomegaly. So one thing would be to manage the ascites and give a good high up enema, so that the constipation is relieved. Absence of
Uh,
vowel sounds might be due to ascites.
if we so the management will give enema instead of bisacodyl sub, is it?
The enema usually we don't get by bisacodyl enema. So I guess Sister Stella might have mentioned how to give a high up enema by attaching a suction catheter to the enema sachet, and we usually give phosphate enemas. You can even use in hepatocellular carcinoma. You can even use lactulose enemas. Good bowel opening is mandatory when the patient is having especially hepatic encephalopathy, because lot of toxins will pass along with the fecal matter and the symptoms will come down with a good bowel opening.
Thank you.
Any other questions? Dr. Sreedevi, can we move on to the case presentation?
Yes, yes, sure.
Okay. Sister Hajja.
Okay, I'm ready.
Yeah, okay.
Okay, can we start now?
Yes, yes.
Okay. Hi everyone, I'm Haja Rosma from 23 Lodge Hospice Kuching, Sarawak. So today, can we go to the next slide? Okay, today I will present, I have a 67-year-old patient, male, with CA colon, post-colectomy and colostomy with partial intestinal obstructions. Next slide. Oh, sorry, sister. I think this is different slide. Hello?
Yeah, yeah.
Yes, doctor. Yeah. Sorry, I think this is different slide.
Is this the one, sister?
No, it's a difference.
This is also different.
Okay.
If it's the same patient story, then you can just tell the missing part, or is it entirely different presentation?
Okay.
So can I show the same one, sister?
Okay. Can I have a slide?
Sure, you can.
I still cannot see the slide.
Share it from your end.
Started with the presenting complaint. Constipation issue. Once patient started with the aqueous morphine for pain management. Bloated with distended abdomen, no flatus and BNO for 3 days, loss of appetite due to the nausea and vomiting. Next slide. Not non-medical illness and not non-allergy. History of diagnosed with CA colon in November 2019 with sigmoid colectomy and colostomy done March 2020. Had 2 cycles of adjuvant chemotherapy and 2 cycles of RT ambulating around. Sorry, because I put here daily BO, but at first, at the previous slide, I put BNO, but this one is happened when before patient started with the aqueous morphine, actually. Next slide. Okay, still with the history. On my day visit, patient developed intestinal obstructions, presented with the nausea and vomiting, abdomen distended, increased pain, and he is admitted for inflamed colon at one of the private hospital here. Next. Patient discharged with fentanyl patch, 50 microgram per hour for 72 hours, uncomfortable, mild abdominal pain on and off, and abdominal bloated but no nausea and vomiting at that time. So daily BO is previously, sorry, it's an error there. And we go to the examinations. Okay, so examination, patient is conscious and orientated to TPP, but the sign is stable, no pale looking, abdomen tense and bloated with very, very sluggish bowel sound when I do the, when I check the bowel sounds, Okay, next. Okay, abdominal bowel sounds done every visit. So the treatment given to the patients, patient received for partial IO. So we have here subcutaneous ranitidine 50 milligram TDS. Subcutaneous Maxalon, at first we give subcutaneous Maxalon 10 milligram TDS, but somehow patient complained of colicky pain. So we change it to subcutaneous haloperidol 2.5 milligram. For the abdominal pain. Another one is subcutaneous dexamethasone 4 milligram BD. As what doctor mentioned just now, it's supposed to be 8 milligram, but we divided into 2 times. That is morning and after morning and evening. So this one also we put in separated subcut pot. Subdecolex, 2 subcut decolex via the stoma. Next. Next. Okay, another treatment is for the pain management. At first, we gave 50 microgram. After that, we increased the fentanyl patch up to 125 microgram per hour over 72 hours. And the aqueous morphine, this is when the patient is tolerating orally, we gave him aqueous morphine 20 milligram BTP. But then, when he is not tolerating anymore, we changed to subcut morphine 2.5 milligram BTP. After that, we started with the CSCI, where we put the morphine 50 milligram and the hyoscine 60 milligram infused at 1 millimeter per hour over 24 hours. And we keep on increasing until at the end up to 100 milligram plus 60 milligram. That is 2 millimeter over 24 hours with the subcut morphine increased to 20 milligram BTP. Next. Next, okay. Psychosocial aspect. My patient married with 4 children and staying with his wife, sons, and the daughter-in-law. Actually, the daughter-in-law is a man carer lah. Okay, stay at his own house at daytime. Normally, he will stay at workshop. At nighttime, he will go back to the house. Wife slightly reluctant for morphine, oral, either oral or injections, because she thought it will make patients more sleepy. Previously, patient was a welder, his own workshop, so there is no carer issue, no financial issue. He is a Buddhist and family is attached and very supportive. Next. Okay, here we can see all the medication. Actually, earlier on, I put already in our treatment, but it's just a list. We have a morphine, tablet, Panto. We have a gabapentin, 30 ml, gabapentin. And we have Coloxil Senna to tap on night with syrup lactulose, Maxalon, ranitidine, Dexa, injections, tablet. Before that is a tablet Maxalon when he is tolerating. After that, we change to subcut. And somehow when he developed colicky pain, so we changed to subcut haloperidol. After that, fentanyl patch, subcut morphine, subdecolate hyoscine, and CSCI. Next. So the main concern is constipation due to the partial intestinal obstruction and of course abdominal pain. Next, summary. Okay, for the summary, 67 all with the CA colon and partial intestinal obstruction presented with abdominal pain increasing with the bloated tense and nausea vomited plus BNO. Actually, he was started with the antibiotic for 3 days for the inflamed. After the CT scan done when he is admitted, started with a partial intestinal obstruction management, actually 2 cycle done, and we put on CSCI, which is we put morphine and hyoscine, and patient rest in peace on the 9th of September. Next. Okay, so I have I have 3 because this is a different slide. Maybe I can read through my notes here. My 3 discussion point is what all can be done for patient's wife regarding your morphine treatment. Number 2, what are the treatment goals of the care for a patient experiencing an intestinal obstructions? And my last discussion point is what is the most common complication which a patient with intestinal obstruction might experience?
Thank you, sister. Is
Okay,
anybody need any more clarification regarding on this patient story? Please ask. Otherwise, we can move on to the what is BNO. I think
can see,
bowel
I
not
can,
open.
They chat here, chat at our chat group, BNO, but BNO means no pass motion, bowel no open.
Okay. Okay, we can move on to the discussion points. Dr. Sreedevi.
Yeah, thank you, sister, for the presentation. And you have done pretty much whatever we have discussed in the presentation, right? You have tried the steroid, tried with the prokinetic, and then the colicky pain started, and then you changed it into haloperidol, and then you changed, so decided that it can be a complete obstruction, and then changed into hyoscine butyl bromide. That exactly that sequence works. And one thing you all have to keep in mind is that never combine a metoclopramide and a hyoscine butyl bromide injections. Both acts extremely opposite actions. One is a prokinetic, that means it increases the bowel movement, and the other one is a gut paralysis agent that will reduce the gut motility. So if you give both together, there is it's a very pharmacological nonsense if you prescribe both together. So exactly like she mentioned, when you start developing colicky pain, you stop the metoclopramide and then you start the hyoscine butyl bromide. So management part, nothing much to comment on because everything has been covered. And it is very common that you may not be, irrespective of whatever rectal measures we do, the patient may not have a bowel opening because the obstruction might have gone too far that you may not be able to manage or have and you know that he is on continuous infusion of hyoscine butyl bromide, so you have literally paralyzed the gut is not moving, no secretion. That means the fecal matter will become more hard and it will not move. So it is not a great attempt to look for a fecal matter because you have reached a point where you just have to focus on patient comfort. You cannot, you may not be able to get a good bowel opening then because you have paralyzed the gut, and that is how it helps most often. Coming to the morphine myths. Even in pain management and in the place where I work, it's very common even among other specialist doctors to ask us, okay, you work in palliative care, that means you sedate your patients with morphine and let them die peacefully. So that is the myth among doctors, that we give morphine so that the patient will sleep and die in sleep. So that you have, and so I don't blame the wife because that is what even the doctors believe in our country, and I don't know what happens in your place, but so you have to so they will relate the drowsiness to morphine. So then you have to explain why the patient is drowsy. So that is how you can tell there is a block. So a lot of tumor will release lot of toxins, everything to the blood, and probably the patient is about to reach end of life care. So once you are going through that phase, usually the people will be more drowsy. When you have more toxins in your body, you will be more drowsy, less responsive. So that is the ideal time to prepare the family that the patient might be probably dying and it is not due to morphine. They may believe or may not believe, but it is our duty to tell them, okay, morphine is not causing drowsiness, but what is causing drowsiness? I think from my experience, I think this is what is causing the drowsiness. Yeah, so someone has suggested that we have to explain the patient's wife how morphine helps. So that is also really important. Why we are giving morphine. So I make sure even to doctors and caregivers, I am not using this drug to sedate the patient. It is not a sedative, it is a painkiller. This is a painkiller like your diclofenac, or you get the medicine Brufen from the medical shop. Exactly, this is also a similar painkiller. Drowsiness can be due to patient's prognosis towards progression towards a dying phase. So that you have to explain almost every day. You may need to explain. We'll explain everything. Next day morning, again the patient or caregiver will tell you the patient is sleepy due to morphine. So it is a continuous process. You cannot just stop with one explanation. It has to happen almost every day.
Actually, on this part, the last 2 weeks, hello, Okay, for the last week, we managed to talk to the wife because all the while when we give the morphine to the patients, actually we ask the permission from patient because patient still awake, still alert, and at the same time we are asking for the man carer, who is the husband, who is the eldest sons and the daughter-in-law also. Actually, we did inform the wife. It just that the wife, when she heard about the words of morphine, because for them it's a drug, so that's why she thought that morphine can make him sleeping all the time. So thanks God that for last 2 weeks before he passed on, so we keep every visit, we keep and explains to her, then finally that she can accept it.
Okay, so that is exactly communicating every day. Even they may not accept till the end, and that is fine. It is our duty to tell them, and we cannot expect that they will accept everything that we say. So yeah, communication is the key there. And I think goals of care, I mentioned it during the presentation. In intestinal obstruction, the goal of care would be definitely symptom management, getting rid of the pain, getting rid of the nausea, vomiting, and constipation, and distension. Obviously, it is very very difficult that we can say it is curable. Generally, it is not curable. It is symptomatically manageable, but may not be curable all the time. So I would say the goal of care would be keeping the patient comfortable. And the moment you see about intestinal obstruction, and even from your patient story, that is a time where you can communicate that it is a really bad prognostic thing. And we have seen that the median survival is 1 to 3 months, right? It may be much lesser than that also. So it is a good time for us to communicate with the patient that this is the goal of care that we are looking for. What is your expectation? This is what we think we can achieve. It is not possible to undergo surgery or cure it completely, and why this is causing a block, why it is happening. So simple explanation. You don't need to tell all the pathogenesis, but still a small example of blocking a pipe, they will understand. Okay, the block is more. Otherwise, they'll be very much worried about the feeding also. The patient is not drinking, not eating. Why these people are not giving anything to drink and eat? Thankfully, this was not mentioned, but that is also very common in bowel obstruction. So we have to explain that whatever we are giving is not going inside because there is a block on the way. So that is one another thing. And a complication, the most common complication is obviously it's very very bad prognosticating factor, bowel obstruction. The survival is very less, and they make even if we recover from the patient will recover from the obstruction, it will recur. They'll come back to you after a few days or a weeks with the same complaints. So the recurrence is one thing. Obviously, the patient moving towards deaths is the complication that I must say. And we have seen a lot of events like uncontrolled vomiting the fecal matter is, I feel, is very distressing, because the patient is aware, patient was conscious, and the patient was vomiting fecal matter all the time, and it is really distressing. Can you imagine the fecal matter coming out through your mouth and you are really conscious? You can smell it, you can see it. And so that is one really really distressing thing, because the caregiver, they can't the moment you close your nose when you go near that patient, he will feel more distressed. So we had to be empathetic that it is not his fault that he is vomiting fecal matter. So we really have to manage it in a very very sensitive way. And the patient wanted to die, because what is the, see, I am vomiting this thing, why should I be alive? Give me something to die. So that was one distressing thing that I have seen. And perforation is another thing. Your bowel can just perforate and burst, like as an emergency. It was with in your time, Sister Sheba, there was a patient who had a bowel perforation suddenly. Um a nurse was there, and I think when we were in SUT hospital, just before I joined. So some nurse has shared their experience that bowel just burst open outside and all the intestinal contents were out when they went inside, and the patient died on the spot. So that is one another distressing thing that can happen. Uh, I would like to hear from other participants also. You might be seeing a lot of, although you may not be able to prescribe medications, but it is a key that the patients will ask you, why can't they correct it with surgery, sister? Is the surgery to cure my cancer? Are they taking out my cancer? So you really have to tell them what is happening. And feeding is a really important thing. In this patient, it has not been a problem, but in our place, that is one problem that we all face. Anyway, he's vomiting and dying, so why don't you feed him? Push a lot of fluids, put a tube and feed him. So once you tell them the concept of block and getting accumulated, then they may not overfeed the patient. Any other participants, either from the presentation or from the topic that we discussed uh, about the signs and symptoms? This is a very important area in terms of your practice and your exam, everything. This is a very tricky area, and once you start reading about bowel obstruction, you become more and more interested in understanding how it happens and how to manage. And in my place, usually the gastroenterology people, they just focus on surgery. The moment they hear obstruction, that means surgery. If it is not possible to operate, then they don't know what to do. So they sent to us for managing bowel obstruction. And usually we can give them good symptom relief, as in this presentation also. They have given morphine and hyacinth butyl bromide infusions. It's a very good move, because the patient will have symptoms up and down, so you cannot rely on intermittent doses. Even we also give continuous subcutaneous infusions, so that there is continuous supply of medication, so there is no vomiting or no pain. So it's a sustained delivery of medication, and which is very commonly needed in bowel obstruction rather than intermittent injections, because the gut will keep moving, right? You can't predict when it is moving. It almost moves all the time. So it is better to give continuous infusions than intermittent doses. Very well managed in terms of medications. Any other questions from other participants?
No more questions, ma'am. We can wind up the session. So, is there any questions? Any last question? No questions. Can we wind up, ma'am? Okay.
There are no questions, then we can.
Okay.